Hi everyone, this is John Mandrola. This is a talk I gave at a Heart Rhythm Society meeting in 2021 in which I was the protagonist in a debate on left atrial appendage closure. This was underwhelming data and overhyped benefits. I've given this talk a number of times and I wanted to record it and put it up so that everybody can see the data and the argument against this procedure. I have no disclosures, and I want to make clear that I'm talking about percutaneous closure. This is different from surgical closure in which the surgeon can actually see it. Percutaneous closure is closure from the inside with a device. I want to start with the basics. This is a preventive strategy for an event that may or may not happen in the future. Remember that stroke or bleeding are unlikely events. Consider that if your stroke risk is super high at 10% per year, that's still a 90% risk of not having a stroke. That's important because you have to balance the procedural risk, the upfront risk, with any future benefit in probabilistic terms. Now, my outline of the argument will be to first consider the divergent results of the two pivotal trials. These are the trials that went to FDA. But before I tell you about the pivotal trials, I want to put three things in context of these. These were non-inferiority trials of Watchman device versus Warfarin. The first thing is that the sample sizes were markedly different. In the anticoagulant trials, Rely is dabigatran, Aristotle is apixaban. These had tens of thousands of patients, much easier to detect rare events. Protect and Prevail, you can see a much smaller sample size, so there's just more inherent uncertainty in the Watchman trials. The anticoagulation trials had a non-inferiority margin of 1.46 and 1.44. The Watchman trials had laxer non-inferiority margins of 2.0 and 1.75. And I want to be clear that this isn't nefarious, but it is important to realize that Watchman had to clear a much lower bar than did the anticoagulants. The third change, this is really important. In the NOAC trials, it was stroke or systemic embolism. But in the Watchman trials, the investigators added another primary endpoint to stroke and systemic embolism, and that was cardiovascular or unexplained death. That may seem like not much, but it is something because these were non-inferiority trials. And remember, in a non-inferiority trial, no difference can be a positive result. And if you add another rarely occurring endpoint that's unlikely to be affected by either treatment arm, it makes non-inferiority easier to reach. Let's start with the first trial, Protect AF. This trial was appendage closure with Watchman versus Warfarin. It had 4-year follow-up, mean age of the patient 71 to 72. The device arm had twice as many patients as the Warfarin arm, and again, 2.3% of the patients in the device arm had a primary endpoint versus 3.8. This was a 40% reduction, and that met non-inferiority. However, there was a divergence in the components of the primary endpoint. If you look at the first component, ischemic stroke, there were actually more strokes in the device arm than in the Warfarin arm. So the benefit of this device was driven by fewer hemorrhagic strokes and fewer CV unexplained death. And this is what I'm going to focus on. I'm going to show you, I think, pretty good evidence that this was a spurious signal in this trial. The reduction of hemorrhagic stroke is likely to be spurious. Look at this difference. Hemorrhagic stroke 0.2 versus 1.1. That's an 85% reduction in hemorrhagic stroke. But if you look at the hemorrhagic stroke rates in the Warfarin arm of randomized controlled trials, 35,000 patients have been studied. Patients on Warfarin, these are the numbers from the randomized trials. And look at the hemorrhagic stroke rates. Look how consistent they are. But look what happens with Protect AF. In Protect AF, the hemorrhagic stroke rate is 1.1%. That's between 2- and 3-fold greater than all the previous trials. That is a spurious signal of a high stroke rate in the warfarin arm. Now, I don't think it was all a play of chance. I want to show you data from the October 2014 FDA meeting. This is publicly available, but of course, if you search journals, you won't find this evidence. This is from the FDA Executive Summary. There were 4 issues with the 10 hemorrhagic strokes that were assigned to warfarin. This is Table 19 from the FDA report, and you can see that there were 3 events adjudicated to Watchman, 10 to the control arm warfarin. Now, what were the issues? Well, one subject who was assigned to warfarin had no CT imaging. The investigators just said it was due to brain bleeding, but how do you know that without an image? 4 subjects were taking antiplatelets plus warfarin. Now, half the events, 5 out of 10 events, occurred after falls, and 4 out of 10 events were associated with a subdural. But look what happens in the Watchman arm. 3 subjects in the Watchman arm fell and suffered subdurals, but these were not adjudicated as brain bleeding. It's certainly peculiar. After the FDA adjudicated these, the number of hemorrhagic strokes went from 3 versus 10 to 7 versus 11. So this still favored the Watchman arm, but the degree of difference was not as great. Now, what about CV unexplained death? This was 1% in the Watchman arm versus 2.4% in the warfarin arm. I'm going to show you that there's 3 reasons why I think that is also a spurious signal. First, that doesn't comport with contemporary trials. Rely and Aristotle had active, this is the CV unexplained death rate in the active arm. But look at PROTECT. Same CHAD score, so about the same risk patients, but here 1.0% CV death, an outlier. The second trial was Prevail, and there was no statistically significant difference in CV unexplained death in Prevail, even though they enrolled a higher risk group. But this is the most important point I'm going to show you. The FDA mandated inspections of the 14 deaths that occurred in Prevail, 8 and 6, and none of these were related to Watchman or warfarin. They were something else that was just not related. So again, likely to be a spurious signal. Due to those problems I just showed you, the FDA says no to PROTECT. There were procedural complications that were too high. There was an overlap of antithrombotic meds in both groups. 26% of the Watchman group was still on warfarin. No reduction in ischemic stroke, as I showed you. There were spuriously high rates of hemorrhagic stroke in the warfarin group. And noteworthy from the editorial that was published along with the PROTECT paper said all patients with ischemic stroke who had their INR measured at the time of their stroke were subtherapeutic. So if it were just the PROTECT AF trial, this device would not have been approved. FDA says do another trial, and the investigators did Prevail. The next part of my argument will be these concerning ischemic stroke signals that were noted in Prevail. Now, this is the data from Prevail. This is a randomized controlled trial. They borrowed patient years from PROTECT AF, higher CHADS VAS score, and again there were 3 endpoints of interest. A first primary efficacy endpoint, that's what PEP stands for, stroke, systemic embolism, CV unexplained death. This is the same as it was in PROTECT. But they added a second primary efficacy endpoint, and they called this the late ischemic efficacy endpoint. And it was just stroke or systemic embolism excluding the first 7 days after randomization. And then there was a safety endpoint. And again, the safety endpoint was safety events, and that met its non-inferiority margin. And indeed, the safety did get better in Prevail. But I want to show you the 5-year outcomes. This is from 2017 JACC paper This is the co-primary efficacy endpoint, the first primary endpoint, number of strokes, embolism, and CV death. In Watchman, 6.6%, Warfarin, 5.1%. And when you looked at the rate ratio, 1.33, so 33% more primary events in the Watchman arm. The upper bound, that confidence interval, 2.13, that exceeded the 1.75 non-inferiority margin. And so in the pivotal trial Prevail, Watchman did not prove non-inferior in the first co-primary efficacy endpoint. Missed non-inferiority. All right, what about this co-primary late ischemic endpoint that excludes the 7 days after randomization? Here, I'll just show you the 5-year data. Look at the 5-year data. The event rate, 2.5%, 1.3%. So right off the bat, you can see it's almost double the amount. And indeed, 2.2 times more events in the Watchman arm. The upper bound here, 4.9, well greater than the non-inferiority margin. So it didn't meet non-inferiority on the basis of the rate ratio. But there had been an agreement that they could also look at non-inferiority based on a rate difference. What's the rate difference? Just 2.5 minus 1.3. Here the rate difference was just 1.2%. The upper bound was right at 2.75, which was the agreed upon non-inferiority margin for the rate difference. And so it did meet non-inferiority barely in this rate difference. However, if you accept non-inferiority on this risk difference, you must also accept the possibility that the Watchman device could be nearly 5-fold worse than Warfarin. And I show you that because the upper bound is 4.9. Now, in 2021, I would ask, is Warfarin even a straw man comparator? And that's because when you look at all of the DOAC versus Warfarin trials, 58,000 patients. This is Christian Roof's meta-analysis of the 4 DOAC versus Warfarin trials. And again, compared to Warfarin, the new anticoagulants reduce stroke and systemic embolism, they reduce major bleeding, and they even reduce hemorrhagic stroke, which is one of the things that the Watchman is supposed to do. So again, Warfarin was the best comparator at the time, but we have better anticoagulants now. Now, what about the net clinical benefit? A patient presenting for this procedure, they have to consider like the net harms versus benefits. And the idea is to close the appendage, and then we can hold the anticoagulation, and we'll have less bleeding. Okay, does that really pan out? Well, here's the Holmes meta-analysis, 2014. This is looking at Protect and Prevail. And I'll highlight you major bleeding all. So all major bleeding. Look at that. No difference between Watchman and Warfarin. Of course, the proponents will point to non-procedure related bleeding, and that favors Watchman. But of course, a patient cannot exclude the peri-procedural time. So if you include the procedure, major bleeding is no different. All right, this isn't just an outlier. There's also something called the CAP registry, which looked at 500 plus patients that had a Watchman device. Here, the bleeding rate was 13.1%. And if you compare that major bleeding in the Warfarin groups of Protect and Prevail, again, that was higher than the Warfarin groups in Protect and Prevail. And you might say, well, it's all due to the procedure. And actually, it's not. If you look at the bleeding rates, they're getting higher over time. And I think that this really questions antiplatelet safety, because remember that even when you have this device in your heart, you may not have to take an anticoagulant, but pretty much everybody stays on aspirin or clopidogrel or some antiplatelet agent. But of course, when you have a foreign body and you take antiplatelet drugs, there's a trade-off. You have to try and prevent these clots on the device. I'll put this slide in here because I want to really have everybody pay attention to the next slide. And as you look at the next slide, remember, Watchman did not reduce ischemic events. Ischemic strokes were actually higher. The benefit's supposed to be in less bleeding because antiplatelets are safer than oral anticoagulants. But are they really? Now, here's a study called Averroes. It's a study I cite often. This was published in New England Journal of Medicine. Connolly is the first author, Stuart Connolly. They randomized 5,600 patients who were felt to be unsuitable for anticoagulation. And they randomized these patients to apixaban, Eliquis, versus aspirin. And apixaban was far superior for stroke prevention. We already know that. But this is major bleeding, okay? Look at this major bleeding. 1.4% with apixaban, 1.2%, absolutely no difference in the intentions to treat. So the whole notion that there's less major bleeding on aspirin than apixaban is not borne out. And these were anticoagulation unsuitable patients. The Birmingham area atrial fib trial, this was published in 2007. 1,000 patients. Look at the mean age, 81 years. And here, warfarin versus aspirin in a randomized controlled trial. Look at this. There's no difference in major hemorrhages, including intracranial hemorrhages, warfarin versus aspirin. My friends, the data that antiplatelets are that much safer than anticoagulants just isn't borne out by randomized controlled trials. Now, foreign bodies in the heart have consequences. Remember, you have to leave this device in the left atrium of the heart. So this is from 2018. This is a study from the Watchman investigators, Protect, Prevail, and 2 registries, 1,700 patients. DRT stands for device-related thrombus. Clots on the device occurred 3.7% of the time. If you had a clot, or the risk factors for having this clot were increased CHADS VAS score, prior stroke, having vascular disease, low heart function, permanent AFib. All of these are pretty typical patients getting implanted with this device. And if you had a device-related thrombus, you had a 4-fold greater rate of stroke. Now, the American data isn't the only data. This is a French study looking at 469 consecutive patients from 8 French centers, a median follow-up of 13 months. Now, some of these were not Watchman. There were some other types of devices. But again, they found device-related thrombus per year of 7.2%. The predictors for having this were sicker, older patients. And the protectors against this was more anticoagulants, more DAPT is dual antiplatelet therapy, OAC is oral anticoagulants. And remember, if you're using anticoagulants or more anti-clot blocking drugs, you're really going against the whole idea of having this device in your heart. Now, to be fair, it's possible that iterative improvements in the device may help reduce this device-related thrombus. Of course, devices always get better. We need the data. The proof is, of course, on the proponents. Now, there's a new Watchman device called Flex that people are excited about. And is this Flex the answer? And let me show you data from a recently published IDE trial, 400 patients, of course, no control arm. And it did meet its safety endpoint. There were 0.5% events. But the efficacy was a little dubious. They reported 12 strokes in 1 year. So that's a 3% stroke rate per year. They also said that 7 of these 400 patients had device-related thrombus, and 3 of the 7 occurred after 350 days, so late. I want to focus on this 3% stroke rate, though. How do we know what that means? Well, we can go to the Rocket AF trial. This was rivaroxaban versus warfarin, and there were 188 strokes, and that's 1.7% or 1.7 per 100 patient years. So again, higher stroke rates than in the rivaroxaban trials. Now, what about bleeding? In the FLEX trial, major bleeding occurred. If you look at 12 months data, this is 7.9%. I put the red box around that. And again, you might wonder, well, what does that mean? Well, again, go back to Rocket AF, major bleeding, any, 5.6% total, and per 100 patient years, 3.6%. So these are historical comparisons, and they're not perfect, but the data from FLEX, it doesn't look that impressive. Now, the net benefit, you have to balance procedural risks because the patient is going to start with a procedural risk, and you're going to have to balance that against any future benefits if there are any. And I went and I added up the procedural risks from PROTECT, Prevail, and the 2 registry studies, and I found that if you average these, you end up with a 6% procedural risk. And people go crazy. They say, that's too high. 6% is way too high. You don't believe me. Well, let me show you this study from 2019. This looked at the readmissions after percutaneous appendage closure. This is a database published in Heart Rhythm. And if you just look at endocardial percutaneous devices, overall complications in the real-world sample of 5,000 procedures, 8.5%. So pretty high. Here's another study looking at inpatient outcomes. Again, from March of 2021, low volume operators had a complication rate of 9.5%, but even high volume operators, 5.6%. So again, my estimate from the trials is not really that much different than real world data. And I wonder whether complications are getting worse. This is a data that just got published. This is a mandated registry. It's called the NCDR registry. It's mandated for Medicare patients. And this was a paper from Freeman, 2020. This was looking at 38,000 procedures from 2016 to 2018. And here I looked at the total number of procedures, 797, divided by 37,000 procedures, major adverse events, and I found a 2.1% rate of major complications. And that people thought that was pretty good. However, another NCDR registry study just came out. This looked at January 2016 to June of 2019, so 6 more months of data, 49,000 procedures. And here they found a 3% rate of major complications. And so how do you get that much increase in just 6 months of data? And here, look at what I found. If you look at the difference in the 6 months from January 2019 to June 30th, 2019, there were 12,000 more procedures, 667 more complications, and so that's a 5.9% rate of major complications. And there may be differences in how this data were extracted, but I really worry that the more we do this procedure, it looks like we're getting worse at it. Now, what about the uncertain pathophysiologic basis for appendage occlusion? That is, pathophysiologic, is there plausibility? Should this appendage closure actually, should it work? And I would really wonder. Stroke is a systemic disease. Way back in many years ago, Virchow has a triad of things that cause a clot, thrombosis, stasis, vessel wall injury, hypercoagulability. And we see this with atrial fibrillation. Patients who have atrial fibrillation have abnormal blood constituents, the D-dimer, the CRP, fibrinogen, things in the blood that make the blood more apt to have thrombogenicity. There's endothelial dysfunction in atrial fibrillation. There's even platelet activation in atrial fibrillation. And so a percutaneous plug in the appendage will affect none of these factors. So again, stroke is a systemic disease. Plugging the appendage is a focal solution. Now, what about randomized controlled trial data? I used to show a blank slide because there wasn't any randomized controlled data to support appendage closure in patients ineligible for anticoagulation. And some people will point to the Prague 17 trial. which was published in JACC in 2020. This was a 10-center study in the Czech Republic, 415 high-risk patients. You can see the numbers here, high stroke risk, kind of a moderate bleeding risk. Now, the authors of Prague 17 chose a non-inferiority design. It was Watchman or appendage occlusion versus any direct-acting oral anticoagulant, and the hazard ratio, a non-inferiority margin, 1.47. But this is the important point. Look at the composite endpoint. Everything is in the composite endpoint. Stroke, TIA, embolism, CV death, these could be considered thrombotic events. And then bleeding and procedure-related device complications, sort of the opposite. And remember, non-inferiority trials, no difference is a positive finding. And indeed, the baseline results showed that there were really no differences in the primary endpoint on NOACs versus appendage occlusion, and the authors concluded that it was non-inferior. Now, I want to go back and show you how non-inferiority should be used. This is the apixaban versus warfarin trial, the Aristotle trial. This was warfarin was the accepted standard. Okay, so what the authors did was they looked at efficacy, primary outcome, stroke or systemic embolism. Was apixaban non-inferior to warfarin? And they used a non-inferiority margin of 1.44, meaning that apixaban could be 44% worse than warfarin and still meet non-inferiority. That's it. That's what they studied, non-inferiority. But for safety, they studied primary safety outcome, major bleeding. They studied superiority. Was apixaban superior to warfarin? And again, they didn't combine bleeding and efficacy in the same. You study one and the other. So the problems with Prague 17 is that the justification of a non-inferiority trial is that efficacy only has to be as good or slightly worse if a therapy has to be safer or less invasive. So examples are the NOACs over warfarin or TAVR over SAVR. The problem with Prague is efficacy, thrombosis, and safety were combined together in the non-inferiority endpoint. And again, Ricky Turgeon, an academic Canadian, said adding up outcomes with opposing mechanisms increases noise. William McIntyre, another Canadian academic, if you include events that you expect to trend in opposite directions, you bias towards the null and make non-inferiority easier to reach. Sanjay Kaul, a trial expert from Cedars-Sinai in Los Angeles, said the same thing. And this is exactly what happened in Prague 17. If you look at thrombotic events, stroke, TIA, CV death, and embolism, there were fewer in the device arm, 4 more in the drug arm. But procedural complications and bleeding were higher in the left atrial appendage arm and went the opposite way. And so they canceled out. Now, also, the rate of procedural complications was 5%. So again, that procedural complication rate of 5 to 6% is real. And 2 of the patients, 2 of 200 in the left atrial appendage closure arm died directly from procedural complications. So my final take on Prague is that it doesn't change my pessimistic priors we ought to have from the Watchman regulatory trials. And I thought to learn whether it is wise to expose patients to this upfront risk of an invasive procedure, we need more data. So in summary, the PROTECT trial, the first trial, did not pass FDA muster. If that's all that we had, the device would not have been approved. The second regulatory trial, Prevail, missed. It missed its non-inferiority endpoint in its first co-primary endpoint, which was stroke, systemic embolism, and CV death. It barely made non-inferiority by rate difference in the second co-primary endpoint, which excluded the 7 days after the procedure. And even if you accept non-inferiority there, you have to accept that Watchman could be 5-fold worse than warfarin for stroke and systemic embolism prevention. The meta-analysis between PROTECT and Prevail showed no difference in major bleeding between the device and warfarin. Procedural complications and bleeding issues will offset the net clinical benefit of this procedure. Remember, Averroes and BAFTA antiplatelet drugs are certainly not benign in older patients. Plus, you have the issue of device-related thrombus. NOACs are certainly better than Warfarin. They have a similar risk of bleeding to antiplatelet drugs, at least if you look at the data. There's a dubious pathophysiologic basis for percutaneous occlusion of the appendage. That is that stroke and systemic embolism are a systemic disease, and closure of the appendage percutaneously is a focal solution. The Prague 17 trial and the US NCDR registry do not persuade me, and the registry certainly had concerning signals. And my conclusions would be that percutaneous closure of the appendage has underwhelming data, overhyped benefits. My caveat, of course, is that I'm open-minded, and if future studies show benefit, I'll certainly change my view. But currently, I do not recommend this procedure based on the evidence and argument that I showed you in this presentation. Thank you very much. You can reach me on Twitter, my Substack, Stop and Think. Appreciate your time.